Welcome back. Well, we've got a lot to get through, so let me introduce our first panel of the day, Child and Adolescent Health during COVID-19, Protecting Vulnerable Children. In times of crisis, it is the vulnerable we must look out for first, including our young. And so as policymakers react to new norms, the most vulnerable should not be overlooked. Against this backdrop, healthcare and social support systems should remain effective and integrated, and day-to-day care for the vulnerable should not be sacrificed. This panel will focus on the big picture, how COVID is and will be impacting children's physical and mental health in our societies globally and in the Middle East and North Africa. It will look at the multiple programmatic implications for national governments and highlight a few areas where ideally all stakeholders could concentrate efforts. Our panel consists of 4 leading experts and policymakers who will discuss what can be done to protect the most vulnerable in society, both within Qatar and internationally. And so let me introduce them. We are joined by Professor Salman Rawaf, Director of the World Health Organization Collaborating Centre for Public Health Education and Training at Imperial College in London, and he joins us from London. Joining from Doha is Professor Khalid Al-Ansari, Chair of the Emergency Medicine Department at Sidra Medicine. We also have with us, joining from Toronto, Dr. Zulfikar Bhutta, who is the chair of the Centre of Global Child Health in Toronto, and also at the Aga Khan Aga Khan University in Karachi, but joining us today from Toronto. Hopefully, we will also be joined by Dr. Luwe Pearson, who is trying to connect from New York. She's the acting director of UNICEF's Health Programme Division. Hopefully we'll be hearing from her soon. But first, before I lead a conversation with the panelists, Dr. Bhutta will share some unpublished recent data and has some slides to show us. Dr. Bhutta.
Well, thank you very much, Louisa, and good morning, good afternoon, and good evening, ladies and gentlemen. Thank you very much for the opportunity to speak to you on an existential crisis that the globe is facing as we speak. So I looked at the figures this morning, and what I will try and cover is principally the 5 key lessons that we have from this current pandemic, its direct and indirect effects on children and adolescents, and then the 5 key actions that we recognize from experience so far, and this is limited to the last 9 months, that can help mitigate, prevent, and reverse the consequences of this adversity. So this morning, the data indicate that we have close to 57 million cases worldwide. And who could have imagined this 9 months ago when we first started to face this crisis substantively? And about 1.36 million deaths worldwide. And the virus has been pretty much universal. It hasn't just affected, as typically pestilence does, low and middle income countries. It has affected North America, it has affected Europe, and it has affected the lives of everybody across the world. The first point to drive home is that children have, fortunately, in terms of the direct effects of the virus, been generally spared. And what we know so far is that it's generally a milder infection in children with negligible mortality, less than 0.2%. And you can see this very clearly in this case comparison across various countries. When you come down in comparison to adults and the elderly, young children have almost negligible mortality. And you see some increase over time, particularly in adolescents who have chronic diseases. But by and large, this is not a big issue in terms of direct effects of the virus. But the second point is very important in that we do recognize now that the indirect effects of COVID-19 infection through control strategies far outweigh the direct effects in children, especially among the poor. And I'd like to illustrate this by work that we've recently done in collaboration with UNICEF in South Asia. So South Asia, in the neighborhood of Qatar, has had its own fair share of COVID-19 infections reflected here by mortality and deaths at population level. And although this may not be as high as you may have seen in Europe and North America, but India has had quite a significant burden of mortality. And you are, in many instances, beginning to see a second upsurge. These countries took action pretty quickly after the onset of the pandemic. And if you look at this slide, which shows you the government response stringency index, which is a combination of measures such as workplace closures, school closures, travel bans, all put in a composite, you will see that very rapidly governments in South Asia cranked up measures. And by the middle of March, beginning of April, almost everybody had closed down. And you will also notice that over time, some countries in that region have begun to open up, and others are still finding their way through it. And this is reflected in something that affects children enormously, which is not just health service coverage interruption, but also things like nutrition, food supply, because of food insecurity, economic impacts through principally joblessness, and interruption in education that I will refer to very shortly. And there are all these secondary consequences of not just the direct health effect, but the indirect effects, the interruption of services, immunization services in many instances that we believe have an impact on health. And because of some of the measures related to lockdowns, families living together, schools being closed, we're also recognizing the mental health impact of this pandemic at family level and amongst children and adolescents. How have we been able to quantify this? So with South Asia, based on not models, but actual data from health services, we've been able to estimate that by the end of this year, in 2020 alone, we estimate that child mortality would go up 14%, an additional 230,000 deaths in South Asia alone, increase in stillbirths, and also an adverse effect on maternal health and mortality that affects newborns. And you will see this reflected in geographies also in Africa. But additional indirect effects that we do not quite measure in terms of impact on mental health, domestic abuse, gender-based violence, we are seeing reports, and our estimation indicates that this is substantively increasing in parts of the world like South Asia, where populations have been impacted by these stringent control measures. The third point that I do want to drive home, and this is also related to the two papers in relevance to the WISH summit that have been published in the BMJ this week. Some of these consequences of these early stressors or toxic stress can really be long-term. In our paper, Chuck Nelson and us, we look at how this early sensitive period in child development, where children are looking at language development, attachment, many of their developmental functions, an interruption in this or a stressful exposure in this can have impacts that go way beyond just childhood. They can have long-term effects through epigenetic influences, neurodevelopmental disruption, and reprogramming of stress and immune regulatory systems in terms of outcomes that can impact cognition, disease prevalence, psychopathology, and also social problems that many recognize from early childhood ill experiences. I talked about school interruptions, and as we speak, the region is, both in South Asia and in Africa, significantly impacted by closures of school in many places. Yesterday, New York just finished all of its schooling that had restarted. Some of this, in terms of its impact on children, can be enormous. What is the figure that we're looking at? In South Asia, we have over 400 million school-age children who've been out of school since March, and about a third can never be reached by remote learning because they just do not have that bandwidth or that access. And this loss in early educational attainment and learning time and acquisition of skills is also compounded by close to around 9 million children that we believe will actually drop out of school completely. And if you look at their long-term consequences, that runs into billions of dollars. The fourth point relates to inequities and gender disparities and the impact of COVID-19. And we were particularly interested in looking at what is the impact on girls, especially girls who drop out of school. And they are disproportionately affected Because when young adolescent girls drop out of school, the usual pathway for them is early marriage. And we estimate that there would be close to around 400,000 excess adolescent pregnancies in the region. And if you look at this quantification of effect, this is a busy slide, but you can see it's distributed across all of these countries that we looked at through adolescent pregnancies, excess maternal ill health as a result of these adolescent pregnancies, newborn deaths, low birth weight, etc. And the lifetime consequences of this in terms of its economic cost can be huge. The final fifth point that I'd like to drive home relates to the region that we look at, with the Middle East or North Africa, Sub-Saharan Africa. These consequences that I've just spoken to you about are much worse and long-term for children and families in conflict settings or in displaced populations. So if you just look at a subset of countries today, which are regarded as the most dangerous places for children in conflict zones, I've already spoken about Afghanistan, but you will see many of these are in the geographies where we do not necessarily have good information on COVID. For example, in many countries in Africa, it looks as if COVID burden does not exist because there isn't the same level of testing or recognition. Somalia is a real example. Yemen is a real example. But the problem is there, and it's compounded by these early exposures and early stresses which already exist. We also have to recognize that displaced people, refugees, about 40% of all the world's displaced people are children. In our second paper that's just come out in the BMJ, looking at these long-term effects of conflict and toxic exposure to displaced populations, we look at a number of areas that are impacted by this early trauma, early financial insecurity, poverty, ill health conditions and disruptions in services, and social isolation and displacement. All of this, as I've already mentioned, not only has adult consequences in terms of long-term adverse outcomes, but can have intergenerational effects, which can be recognized for several generations to come, as has been the experience from conflict elsewhere. So on the surface, this may look like a doom and gloom scenario, but friends, the reality is that the world and many of the people who have been talking about this for the last 9-10 months rose up to the challenge, and there are some very refreshing examples of how people have worked to reverse and to mitigate some of these secondary indirect effects. So what has worked, and what has worked potentially that can be taken up to scale? So first is, there has been an enormous upsurge in social safety nets and cash transfers. And these have been at scale, have targeted women, and they have begun to impact some of the positive responses that can protect children in vulnerable families. In my own country of origin, in Pakistan alone, the government launched one of the largest social safety nets through a program that specifically targets women. Lots of examples of this happening elsewhere as well. Early nurturing care and support for young children is something that we all stand behind. And this has also been tested in terms of responses through strategies that have healthcare workers reaching out to people when they could not come to facilities. And those are the large community health workers and outreach programs. They've had to have the appropriate safety measures, but they have been able to provide ambulatory and domiciliary services to the poorest of the poor, and even in many urban slums in populations where the disease has been kept under control. We have some very interesting pilots from non-governmental organizations and small-scale implementation of mental and reproductive health support strategies, especially for adolescents. And these are very interesting in terms of their ability to provide support when support services don't exist because of closures. And finally, I think the greatest example of success that we can see is that despite the fact that immunizations were interrupted quite significantly, that we have been able to build back immunization coverage pretty rapidly through both routine services as well as mini campaigns. And if my friend, Dr. Louis Pearson, is able to join, she will speak a little bit more about it. But I can quickly give you one example of my own geography, which is, the province of Sindh, where you can see a interruption in the lockdown and quite a significant reduction during the period where vaccinators just could not work. But when it was rebuilt and rehabilitated, you can see that people just did not bounce back to where they were before. That in many instances, supervisory work went over and above what was required. So there is a clear opportunity to rebuild and build back better and to achieve higher rates of coverage of immunizations in the wake of COVID-19. So I want to finish by just citing from one of the greatest sages that we have had, who knew about science, he knew about technology, he knew about what needs to happen. And what Einstein said was, in the midst of every crisis lies great opportunity. And I hope that some of this conversation today will help us realize the enormous opportunity we have to protect and support the most vulnerable in the poorest of the poor in our midst. Thank you very much for your attention, and I look forward to the conversation.
Dr. Bhutta, thank you very much indeed. And a very quick question to you off the back of that before I open up to the panelists. And what stood out for me was the fact that you say that there are still gaps in the overall picture. So we don't really have a clear picture, do we?
Well, we have a reasonable picture, I would say. I mean, clearly, the level of testing, just given the cost of testing, cannot be the same worldwide. No country can afford testing rates at the level that the United States has been able to implement, but countries have done reasonably well. So, except for some of the very remote populations, countries in the midst of conflict, where there are populations on the move, I think we have a reasonable picture of at least COVID-related mortality. As Professor Rawaf will tell you, it's very difficult to hide deaths. And if there is excess mortality, generally one is able to get it, particularly in populations where deaths have to have a burial or a cremation. So we do recognize that the burden of ill effects of COVID have not been distributed equally worldwide, and that many low-income countries in Africa and South Asia have not seen the same level of adverse effects. But we have to recognize that in terms of incidence data and information related to confirmed cases on PCR, we just don't have the same level of testing worldwide.
Okay, thank you. Well, we've heard there then from Dr. Bhutta the big picture, and now to you both, Professor Rawaf and Dr. Al-Ansari. I want to ask, based on your experiences and the evidence that you're seeing in your roles, what aspect of COVID do you think has really had the most impact on vulnerable children and adolescents? And I know that there are lots of different issues and it's really difficult to pinpoint one thing, but as a headline, for example, to get us started in this debate, what do you think has been the biggest impact?
Well, thank you very much, and thank you for the opportunity. I thank Professor Bhutta for excellent presentation. He summarized the whole things in such a crispy way. I think the biggest problem is that with this pandemic, we were not prepared. If we were prepared, these all eventualities, which is beautifully illustrated by Professor Bhutta, wouldn't happen. And yes, we were prepared to deal with acute event, but not to that magnitude. And all public health authorities, health systems, etc., taken by surprise. The victim of that is not only children, but the entire populations which we serve worldwide, as we see now across Europe, and indeed across the Middle East in some countries like Jordan, Lebanon. We see it also in other big countries like Afghanistan, Pakistan, etc. But I think the children were victim in a way because of this, what happened socially, not medically. Majority of the families shifted their priorities from their children to struggle to survive, especially when many families were threatened with unemployment, lack of money, etc. The health services didn't really pay the attention needed initially. I'm glad many of these were corrected and we could really touch on these in the due course.
Yeah, definitely. Thank you. So for you, the biggest impact has been the social impact on children and adolescents. And Dr. Khalid Al-Ansari in Qatar, for you there, what has been the main impact there, do you think?
So I think the social impact is worldwide for those kids. And, I think we would see the medical impact when you look at the more vulnerable group of those vulnerable patients. Now, as you have mentioned, Louisa, children are a vulnerable group, but among those group, there are kids that are more vulnerable, like, special need children, children with malignancy, immune deficiency, children who are more prone to abuse. So those kids would require a better access to care, would require to be seen more oftenly, would require the medical staff to be more attentive to their need. And an example of an effect of COVID on that is the child abuse and the reported cases of child abuse. I can tell you during the COVID period, we reported 30% less cases were referred to the child abuse center. Right? So the number of cases that we got or were referred to the child abuse center in Qatar were 30% less. Probably that's because, people who are in contact with those kids at school or neighbors or relatives are not in contact anymore, especially with the lockdown and the homeschooling and so forth. And I think a proof of that, we started seeing at least double the number of severe cases of child abuse. We started seeing the full-blown shaken baby syndrome in a double figure as compared to the previous years, and the significant physical abuse in children. So there is something going on. It's happening. It's more severe, but they are not reported as often as you would like them to be reported. And this is only an example of that, a special vulnerable group.
So let me understand, you know that fewer cases have been reported, but you know that cases of abuse, for example, in shaken baby syndrome, have increased. So basically, those cases of abuse are only coming to the fore when they are extremely serious, when they should really have been reported earlier.
And, I'm mentioning the child abuse as an example. I would bet you that this applies to the other vulnerable group, simply by looking at patients who seek care in the emergency department or attend the outpatient clinic. You can find a significant drop there.
Yes, please, Professor Rawaf.
Yeah, we have seen, Professor Khalid is absolutely correct. We have seen a reduction in use of the health services. Even emergency department have seen a drop of by something like 70% in some places. But you see, the problem, there are two factors driving these problems, especially among children. Number one is fear of the infection, Secondly, which is really, really worrying all of us, is the misinformation, especially the misinformation spread by colleagues. Some of them are prominent colleagues, So
what sort of misinformation exactly?
A lot of misinformation happening, during this epidemic. Misinformation that the virus is not going to affect children, the transmission. Children is not transmitting the virus at all. Misinformation about the severity of the disease, misinformation about the conspiracy theories, misinformation. It's become a science by itself. It's worrying authorities now around the world, and some countries trying to introduce legislative framework to prevent that from creating that fear among the population, or even in some population, unnecessarily dismissal of the virus, dismissal of the intervention, dismissal of reaching the social and health network needed.
So you think misinformation has really been a problem as well. But I've also wanted to ask you about how people have adapted much of life, whether business, social, some services also have adapted well to the shift online and to the virtual world. But when it comes to child protection and health services, has that also been a problem in detecting cases of vulnerable children?
We have adapted well. If you look at the health services within, we published a paper or two on this issue, within such a short period of time, doctors manage within especially primary care to revert to virtual consultation. Today is almost in any pediatric department, in any primary care center, actually 90% of the consultation are virtual. But for children, this is not enough. Children love to be seen, you know. We love to see them. I cannot discover whether a child is suffering from physical abuse, for example. I cannot look at the child and all his family environment in a virtual setting, because sometimes the virtual setting is quite misleading, you know. It's nice to see them physically, and we encourage, and if you look at United Kingdom and some of the Arab countries, we encourage primary care to go back to some sort of normality in terms of providing the essential services, giving support to the children, at the same time protecting anyone from getting unnecessarily transmission of the virus.
Dr. Al-Ansari, is that the same situation in Qatar then, that seeing children virtually just, it doesn't work?
I think it's worldwide. I think we have not picked up from this, from this virtual yet. We went to the virtual, the virus attacked us really fast. We went to the virtual just to protect everyone, the medical staff and the patient themselves. Children need is more than virtual, right? It's a third person who gives you the information. You cannot rely on the virtual to get really a correct and the full picture. Access to care has to be more than virtual, and the medical services has to start picking up on that. They have to see, and the needs of every patient has to be individualized. We need to decide when virtual is okay, or we need to get the patients to the service to look at him, or maybe refer the patient to home care, or pay the patient a visit by medical staff. This is not a normal situation, so I think we need to come up with ways to improve access of care to those patients and their families.
Yeah, and of course, when children aren't going to school, when they're not playing in the neighborhood, for example, then there aren't those other voices, the teachers, the neighbors, those in the community who can raise any issues as well. I think that we have been joined now by Dr. Luwe Pearson from New York. So once I can make contact with her, yes, you are there, Dr. Pearson. Thank you so much for joining us. I'll be coming to you shortly, but just another question quickly to Dr. Khalid Al-Ansari. What about the challenges raised by other forms of technology, for example, social media when it comes to children?
Social media has been a bliss probably to parents that has helped them engage their kids during the difficult time. Most parents are stressed psychologically, many of them financially, many of them have lost their job. And keeping your child engaged at home is something great. Now, we have to remember that kids do homeschooling that has increased the burden to parents. But attention to what kind of material your kids get into and the social media, and what kind of, and the monitoring that you still have to do during that time. Social media can be very disruptive and damaging if there is no enough control to whatever your kids get into. I think there has been more violation of private information, confidential information. There has been, some more addiction to social media from kids' side. And we will probably start seeing the mental, psychological, and physical long-term effect of social media and net probably soon with this COVID, especially if it, since it's expected to continue for a year or two more.
However, on the other hand, for example, I know from my own experience with my son, having video gaming and being able to connect and communicate with his friends through games was an absolute lifesaver for him during lockdown, because he's too young to have a cell phone, a mobile phone, so he can't just pick up the phone and talk to his friends. So actually we were increasing his screen time, whereas normally we're always fighting to reduce it. We actually found we had to increase it so he could at least speak to his friends. And, you know, so technology can be positive as well, can't it?
Yeah.
But just as a caveat, if I may, I think, you know, technology, yes, has been a panacea in many cases for virtual consultations, education. But remember, the vast majority of the poor children of the world don't have access to this. Yeah. Even in terms of education services, a lot has been made out of virtual schooling. The poorest of the poor have not had access to it. Many places just do not have either the technology or access or the ability to do this. So I don't think that's been sufficient. And I think the excess increase in screen time may have worked in a short time period, but do remember, it's very difficult to wean children off that. If they've got used to spending an extra 2-3 hours every day glued to their handheld device or PlayStation, try and get that to reverse once things are back to near normal. It's going to be very challenging.
So is the chasm between rich and poor, rich nations and poorer nations, and the technology divide, or the chasm between them, is that going to be even more noticeable as we come out of this period?
Absolutely. And it's not just between high income and low income countries, Louisa. These differentials have been noted in high income countries as well. Just look at the differences in mortality rate and differences in access to services between various socioeconomic groups and on the basis of color and race in North America. And you will be astonished as to how wide those gaps are. So as you know, as Salman was pointing out, this is basically where you look at social determinants of health and see how they have profoundly influenced some of the outcomes of this pandemic. But let me come back to this. I mean, we know all of this now. I think the important thing to focus on is how can we mitigate and prevent these things and reduce them? And as we rebuild services, and I'm itching to hear from Louis, how can we actually go back to not just where we were before, but we can go back to a better place in the future?
Yes, well, we definitely want to move on to talking about building back better shortly. So yes, let's bring in Dr. Louis there. Thank you very much, Zulfikar Bhutta. And Louis, thank you for connecting with us from New York. I know technology can sometimes not cooperate the way we want. And you actually have some data on the magnitude and scale of impact of the pandemic on children. Can you give us a quick overview, please?
Sure. I have 2 slides, and it has been tested by a few minutes ago. I'm not sure if it is visible to you.
It is.
It is, good. In UNICEF, first of all, I'm Louis, working in UNICEF New York as a principal advisor in the health section. We looked at how the pandemic is affecting essential health services, because the epidemiological factors are not all known. In April, the world predicted a severe interruption pattern of services that could result in 6,000 additional children's lives every day. That is 6,000 additional deaths every day. We looked at Q2 this year and the Q2 2019 data. I'm just presenting 2 indicators. One is the immunization coverage among children. We saw the interruption pattern is very different across the globe. In Peru and Pakistan and a few other countries, the majority of the children, up to 50-60%, have been affected and have missed immunization. And in West Africa, there are not many children affected. In fact, they have reported increasing immunization, children immunized during Q2 this year compared to last year. And we thought this could be affected by the disease burden. If you look at the COVID-19 cases per million population, it's also related to the design of the frontline services. if we're able to provide outreach and the community-based services safe. We have seen recovery of immunization services during Q3, but the analysis is not complete. And if I look at the, oh, I should have another slide.
Do we have another slide for Dr. Pearson?
It is only, I can just speak to it on the skilled birth attendant. The pattern is quite similar. Again, it's quite different across the world, but the notion is the missed skilled birth services. Once a woman has delivered at home, once a baby is born with complications not to be managed, these are opportunities lost forever. So for UNICEF, we are watching several important things. The first is the best interest of children. While we control the pandemic, are we able to offer are we able to look after the best interests of children in terms of schooling, in terms of safe space, and in terms of essential services? We're watching finance and the budget. Is money being moved away from COVID-19 to essential services, from essential services? That is really critical, because we can save lives from COVID-19, but we can lose lives from other reasons. And the last thing to say from UNICEF, we want to be the safe guardian for the interests of children. We are sure that many things in the world are political choices that the politicians need to make for the best interest of children. Thank you.
Yeah, and Zulfikar Bhutta was talking earlier before you joined us about the indirect effects that have really impacted on children. For example, stringency measures. Do you think that the response to the pandemic globally then failed to take into consideration what's in children's best interests, or do you think it was too knee-jerk reaction?
Yes, there are many knee-jerk reactions, and we are also learning how to do things better. For example, Yemen, a country in your region, has started immunization campaigns by giving face masks and hand sanitizers to community health workers and the vaccinators. So they have seen that people are willing to come back to receive the services. So yes, there are many things we could have done better, but we will build the health system back stronger from the lessons we learned.
How exactly are we going to do that, everybody? Have any of you got the thoughts as to how we build back better? Professor Rawaf, you raise your hand there. We just need your microphone on, please, sir.
Salman, you're muted.
Let us first of all get rid of what is called pandemic fatigue. There is so much fatigue among policymakers. There's so much really tiredness among people in charge of the system as well as the public. Secondly, we have to address the inequalities, which is already mentioned, the inequalities in reaching services, the inequality in reaching technology, the inequality in reaching food and the income, substitution for the income lost. We've seen today on CNN actually queues of families for food bank. They cannot feed their children. I mean, these are priorities. Yes, we are now much better versed with the pandemic. Yes, we put much more precise public health measure, depending on precise epidemiological data and projection. We are by far much better as far as this. But the social aspect, the wider determinant, we are not yet giving it the priority it deserves. And I think honestly, policymakers need to move in that direction. The health side could be managed, and I think we are well prepared for it, whether public health authorities or indeed health services are doing extremely well in managing services admitted to the hospital. But that social aspect need to be addressed, and the issues of inequality need to be addressed.
Thank you. Dr. Butta?
So I completely concur, and I think this pandemic gives us an enormous opportunity and reason to focus on what we signed up in 2015 as the Sustainable Development Goals. The Sustainable Development Goals that all the countries of the world signed up to in 2015, benchmarking where we want to go by 2030, were totally geared towards eliminating some of these underlying social determinants and differentials in health, as well as in other things like access, education, poverty, etc. If you look at the genesis of this global pandemic, even though we do not have enough knowledge, the fact is that its impact in many different populations has been directly reflective of social disparities within those populations. And this should open our eyes in terms of how we need to do things differently, whether it is low and middle income countries or high income countries, to reach those people, to provide some type of effective services to the most vulnerable, to ensure that people have equal opportunities, to ensure that our data systems capture those on a regular basis is the global challenge now. And I think we are all beginning to recognize that this pandemic also opens our eyes to how vulnerable we are as a single planet to things that happen in the ecosystem. I mean, sooner or later, people will begin to wonder, how come we got such a virus coming out all of a sudden? And what were the determinants of this? So just like Ebola, just like Zika, coronavirus also arises when there are pressures on the ecosystem, when we do have things such as climate change, urbanization, deforestation, the One Health concept of living with our environment and animals. When all of those things are disrupted, you will have risks of these kinds of outbreaks and pandemics. And therefore, moving forward, I hope, Louisa, that we will be looking at a much more holistic response than these Band-Aid measures of here is something in immunization, let's fix it. Here is something in health that we fix, or education. I think this requires a level of global solidarity around addressing these social disparities. It also requires global solidarity in information seeking and information sharing. My final point on this is, I think we should look at the positives out of this also. And as you can recognize, although there are many things that we don't know, the world's response to this global pandemic in terms of scientific information sharing, in working together to produce diagnostics, vaccines, and to also have a global dialogue on how are we going to get those vaccines to the poorest of the poor, has been unprecedented. Frankly, if you had asked this a year ago or less than a year ago, whether we will be able to mount a scientific response of data sharing, whether we would have a dialogue worldwide where the COVAX, the vaccination facilities, will be able to get these expensive new vaccines to the poorest countries, I would have said maybe not, because this has not happened before, but we have made that change. And I think on the positive and optimistic outlook, I am looking at 2021 being a lot more positive and optimistic in terms of how the world will move together. But the key there, just to close, is political and effective ownership and leadership worldwide, not just by one or two countries, but all the global political leadership on standing together, getting out of this denial mode, and just looking at scientific basis for their decision making.
Thank you very much. And Dr. Butta there mentioned a holistic approach, needing to do things differently. In Qatar, Dr. Al-Ansari, are you already starting to think on those lines? How are you addressing these problems looking forward?
I will talk about the perspective of direct clinical care providers and people who work in hospitals and healthcare in the country. I think it's very important, as I've mentioned, one of the learning lessons is access to care to our patients. Try to come up, individualize that access of care, especially to the high-risk population, and come up with different ways of providing the service and delivery of care to that population. I think this is a big challenge and learning lesson for us who works directly with patient care.
So is it about coordinating multi-sectors, multi-disciplines? Is that the approach that you are going to be focusing on even more?
Absolutely. So you will need to, it will be more of a collaboration. It will be more of a teamwork. It will be more of a fill in the gap of what resources are in existence with the multiple stakeholders, trying to provide the max that you can to that, to those kids and families.
Right, thank you for that. We will be taking some audience questions soon, but as we wait for them to come in, a question to you, Dr. Pearson, in New York, based on the lessons that we've learned this time, how ready do you think we are for a future pandemic?
Thank you for the question. I'm looking at two things where UNICEF can support the countries. First is the information system, and the second is the supply chain. I can explain more. The data you have seen, that one slide I was able to share. Actually, we got the information with a lot of difficulties. The government, in the beginning of the pandemic, were very reluctant to share information on real-time basis for various reasons, and partly is not to be blamed for certain gaps of services. But now I think that the government is ready to share information to allow us to monitor the essential services on real-time basis. And the second is the supply chain. The production capacity and the transport capacity of protective equipment, oxygen concentrators, and many other things in March, April, May were very much blocked, and now it's getting a lot better. So we need to learn as a global community how to keep the supply chain operational. We can overcome COVID-19 eventually, but there could be another pandemic. We need to get our primary healthcare systems ready for the future potential interruptions.
Thank you for that. Any other thoughts then on the same subject, and based on the lessons we've learned, how ready you think we are for future pandemics?
I think we will be better equipped, and I really strongly believe that there will be more pandemic of similar nature, even more aggressive. What Professor Bouta mentioned in terms of the ecology and what happened in the global environment will continue to have these sort of impact and spread of diseases, which are unknown to us now. But memory tend to be short. I mean, once this pandemic over in a year or two, I don't think the pandemic will disappear simply because somebody introduced a vaccine, which is a fantastic development. We have to live with this pandemic for some time to come. And the problem is not those people, unfortunately, infected. The problem is the 90% of people who are not, those people need to protect themselves. Government need to protect them and support them. But that preparation in the future need to be totally different. It's not only a new health system, which more resilience we need, a new public health, which required to be more active, more precise, but also the economy, the government, the scientific community, all they need to come together. They need to plan together. there is nothing in the future which is called public health planning, health service planning, economic planning, community. This is nonsense. And we have to bring all these elements together, and we put the issues on the table, because a pandemic of these natures are actually multi-dimensional, have multifaceted appearances, and it needs multi-dimensional approaches.
Yes, indeed. Thank you very much for that, Professor Rawaf. We've got some questions coming in now, and Dr. Al-Ansari, I was asking you about what you think the approach is going to focus on even more in Qatar, and I've got one asking if you can tell us more about the Sidra Child Advocacy Programme at the hospital and what else needs to be done for vulnerable children in Qatar. If you could put your mic on, please, Dr. Al-Ansari. Thank you so much.
Yeah. So the Child Advocacy Program has started around 4 years back, and it's a national program where in all cases of suspected child abuse are referred to and investigated for the possibility of child abuse, and then all the services, a multi-stakeholder and multidisciplinary service is provided to children who are disadvantaged with the child abuse or suspected to have child abuse.
Okay, thank you very much for that. I hope that answers that question. And we were talking a lot about technology, about internet access for children. We've got a few questions on that, so if we could go back to that topic, please. What are the immediate recommendations for helping children without internet access? What happens to those children? Do they just get forgotten about? Their education stops?
No, and I think the reality is many people were very aware of this before. So, for example, I can tell you that in Pakistan, the government started a television channel for education because they recognized that internet access bandwidth would be a big issue. And that's been running for several months now. In other instances, a much more mobile approach. See, one of the difficulties with all of this was that you could not get children together in a learning environment where they feed off each other, they work together, and that could not be substituted. And therefore, in some, particularly in displaced populations, refugee camp settings, there have been approaches which have tried to look at alternative forms of education using outreach workers. But by and large, there is no substitute to education through an alternative mechanism. And therefore, now that we have much better data on transmission, I think Salman was referring to that, a lot of myths about children being super spreaders, which is not necessarily the case. I mean, there is a gradient, of course, but I think the last thing we should do in any circumstance is really keep our schools closed. And as I showed you from South Asia, the policy response is also very variable. In the same region, in the same subcontinent, there are countries that have opened up their education systems. And there are others where children have just not been to school for the last 9-10 months. So we need to have a unified policy response. And our default position right now is that with the safe measures, with the appropriate mitigation, with hand sanitizers, with use of masks, children should go back to school now, because otherwise you run the risk of losing 1 year of education in certain children. And I've already spoken about those who would drop out altogether. And that 1 year for a very critical time period, let's say very young children, preschoolers and children between 3 and 5 years of age, can have huge consequences developmentally. So I think Louis will have some thoughts on this also.
Yes, Louis, please do.
Thank you. Professor Bhuta, that is exactly UNICEF's position, that schools should be the first ones to open up if a society decides to open up. We don't want to see restaurants and bars and cinemas open before school, right? And we need to get our priorities right. And secondly, in many of the schools, the basic infrastructure are not sufficient in terms of hand washing, in terms of keeping keeping children safe physically. And for example, the road, we're looking at the road before schools. Can we have better safe measures by better limit control? So COVID-19 has also given us the opportunity to build school better and safer, not just teaching, but the overall environment. And we think school is a very important place. What I personally learned in America in the past 5 years is how in every district, school is the center of everybody's life. Mm-hmm. People want to have the best schools for their children. And this is not the notion for the developing world. For the developing world, it's something else that is most important.
Yeah. Dr. Pearson, thank you so much. To all of you, we are running out of time. We just have a few minutes left. So I'd like to give you each 1 minute, please, just to summarise or conclude your thoughts as to how best societies and nations can look out for vulnerable children and adolescents. And if we can start, please, with Dr. Khalid Al-Ansari in Doha, a minute to summarise your thoughts, please.
I think the pandemic has showed that one hand cannot clap. We need to work collaboratively, hand in hand, from all disciplines all over the world to come up with the best solution, collaborate, work together to get over this health crisis, world health crisis, and be ready for the future one if there would be in few years.
Thank you so much. And Professor Rawaf?
Well, thank you very much. I think our children are our priorities. We should really put that slogan. These are the priority which we should focus on. We should, as I said earlier, come all together to address the need of these children, healthy as well as vulnerable children. All children are the same, and all children must receive equal treatment and equal access to services, including education, school. And indeed, the pandemic reminds us how, even in the Western world and the very rich countries, how the schools are poorly designed and poorly equipped. You know, it's a great opportunity in looking at the classes and how things are shaped differently in the near future.
Thank you very much, Professor Rawaf. And Dr. Pearson?
It is very important for UNICEF to be present at the front line to support every country. In 190 countries over the world, we're at the front line. Let it be Qatar, let it be Pakistan, or everywhere. And you can count on UNICEF to support each of you and the government and local institutions to build the system back better and to take care of every child and their family, no matter where they are and who they are.
Thank you very much, Dr. Pearson. And Zulfikar Bhutta, please, your concluding thoughts.
Well, thank you very much. This has been a fascinating panel, and I concur with most of the things that my valued colleagues have said. But I want to finish maybe by saying that we forgot the Birkenhead drill. And to those who know what that is, that's a long established tradition in maritime disasters of letting women and children off first, is protecting women and children first. And I think in international health regulations, that's got to be the dominant thing, even though we may have sometimes reactions at a population level. So I think what we need to do henceforth, since I do agree that we will face similar crises again, every time a crisis like this comes, we think that's the last one. That's not going to be the case. We need to be better prepared as a global public health and education community as to how we deal with something like this putting the most vulnerable of the vulnerable, the women and children in the poorest section of society first. The second thing that I would say as I close is, this also tells us how interconnected things are. That we may live in different countries. I may be speaking to you today from Canada, Salman in United Kingdom, Louis in New York, and Khalid in Qatar. But the world is a global village, and we are all linked together in ways that was not the case 50 or 100 years ago. So, to some extent, the analogies with the great flu pandemic of 100+ years ago do not hold true, because we are much more linked, connected, and the rapidity and speed with which things spread is much greater. But that also means that the rapidity of our response can be equally fast, that we don't have to wait like the global pandemic, flu pandemic, to lose 50, 60 million people worldwide, that we could bring this to a close much faster, but only if we stand together. And hence my point about global solidarity and political leadership and governance in this.
Thank you very much, Dr. Butta. Thank you all. Well, so we've been hearing there how COVID is affecting vulnerable children, or making some of them even more vulnerable in different ways, socially, through lack of education, through lack of vital services that would be able to detect the vulnerabilities and abuses. And we've heard there from our panelists that overriding thought that we need to take a more holistic approach, the whole world does, and that global leadership really needs to stand together if we're going to be able to get through another pandemic situation like this. So thank you all so much to my panel, Professor Salman Rawaf from the World Health Organization's Collaborating Center for Public Health Education and Training, to Professor Khalid Al-Ansari from Sidra Medicine in Qatar, Dr. Louis Pearson, UNICEF, speaking to us from New York, and Dr. Zulfikar Butta, speaking to us from Toronto, from the Center for Global Child Health. Thank you, all of you. Thank you very much.
Thank you.